Accelerated coronary artery disease in a young patient with multiple endocrine neoplasia. A case report. Presented by internal medicine residents at Orlando Regional Medical Center. Multiple endocrine neoplasia 2A is characterized by medullary thyroid cancer, pheochromocytoma, and parathyroid hyperplasia. The adrenergic state caused by MEN2A has a propensity to cause heart failure. However, accelerated coronary artery disease in the young is a unique consequence. We will discuss the mechanism of how MEN2A can cause coronary artery disease in the young. In our case, we have a 27-year-old female with a past medical history of hypertension and hyperthyroidism who presented with chest pain and palpitations for one day. Initial vital signs revealed hypertension and tachycardia. The physical examination demonstrated no chest wall tenderness or abnormal heart sounds. Labs showed elevated troponin, low thyroid stimulating hormone, hypercalcemia, and low magnesium. EKG confirmed non-ST elevation myocardial infarction, and a left heart catheterization revealed 80% stenosis of the proximal left anterior descending artery. A drug-eluting stent was placed. This led us to the question of why such a young patient would present with severe stenosis without the typical risk factors. Labs demonstrated elevated calcitonin and parathyroid hormone, as well as a serum and urine catecholamine, suggesting a triad of MEN2A. Now let's examine the images and biopsies performed. Due to the elevated metanephrines, an abdominal MRI was ordered, which revealed a large right adrenal mass, approximately 9.5 centimeters by 7.7 centimeters, clearly seen in the left image. General surgery was consulted and started the patient on doxazosine for alpha blockade prior to surgical removal. Subsequently, biopsies demonstrated large polygonal cells with abundant cytoplasm in a nested pattern, positive for chromogranin, as seen in the images on the right. This confirmed a diagnosis of pheochromocytoma. It is uncertain how pheochromocytoma can cause coronary artery disease. However, multiple mechanisms have been proposed. One is due to a surge of catecholamines that leads to increased levels of factor VIII and von Willebrand factor, which induces platelet activation. Another mechanism is by increased plasminogen activator inhibitor 1, which is co-released with catecholamines, causing thrombotic events. Lastly, vasospasm causes microvascular dysfunction secondary to increased catecholamine secretion. A thyroid ultrasound revealed bilateral thyroid nodules measuring up to 1.7 centimeters. Head and neck surgery performed a complete thyroidectomy, and the biopsy demonstrated spindled cells in nests and cords, positive for calcitonin with background stroma containing amyloid deposits and entrapped benign follicles. This confirmed a diagnosis of medullary thyroid carcinoma. In addition, a nuclear medicine parathyroid scan was ordered and showed a parathyroid adenoma as seen on the image on the left. Staining was revealing for benign parathyroid cells composed of chief and oxyphil cells as seen on the right. The elevation of calcium seen in primary hyperparathyroidism causes additional calcium deposition in the coronary arteries. Additionally, hyperparathyroidism is shown to alter the vasodilatory properties of the endothelium, leading to hypertension. This combined effect is the perfect recipe for accelerated atherosclerosis. In the video on the left, you can see the left heart catheterization demonstrating 80% stenosis of the proximal left anterior descending artery. And on the right, you can see how this changed after she received the drug-eluting stent. Upon discharge, the patient was started on levothyroxine, calcitriol, oral calcium, beta blocker, and was referred to oncology and genetic counseling. We believe the presence of MEN2A plays a crucial role in the development of coronary artery disease. There are two primary key points to take away from this case. First, patients with MEN2A could benefit from aggressive risk factor modification due to their increased risk for accelerated coronary artery disease. Second, in younger patients presenting with atypical chest pain with a history of MEN2A, a low threshold for further cardiac workup could be beneficial. Thank you for your time and attention.